So thank you for joining us on this, our latest media briefing on important healthcare issues in the news. I'm Dr. Rose Zacharias, President at the Ontario Medical Association, which represents more than 43,000 doctors in Ontario. The COVID-19 pandemic tested Ontario's healthcare system in unprecedented ways, highlighting the cracks that existed before the virus arrived here in early 2020. Our system is in dire need of immediate solutions. Too many Ontarians don't have a family doctor, so they have trouble accessing the rest of the healthcare system. Wait for specialists are long, so patients can't get diagnostic tests or surgeries when they need them. Hospitals don't have enough beds to treat acute care patients because too many of those beds are occupied by people who have nowhere else to recover. Emergency departments are seeing large numbers of patients turning up sicker. I've been an emergency department physician for 20 years. Never did I think we would see the day that emergency department doors would close because of overcapacity, but that has indeed been the case. Physicians and other healthcare workers are suffering from burnout, mostly due to administrative burden. Ontario's doctors have a comprehensive overall plan to fix the healthcare system. Our prescription for Ontario, doctors' 5-point plan for better healthcare. The prescription is an integrated plan that the government and stakeholders can implement over the next few years. We will be updating our prescription in the coming months to reflect the progress that we have made so far and to recommend how to support family doctors who are the bedrock of the healthcare system. But there are 3 things that we can do right now to increase capacity in the healthcare system and improve patient access to care. That's why the OMA is urging the government to include these things in its 2023-2024 budget. Our first solution is to find and keep more doctors. We need to license more doctors to address the doctor shortage and keep the ones we have by reducing the administrative burden. We support the government plan to introduce a practice-ready assessment program for physicians who graduated from medical school and practiced abroad, but we want to move quickly and increase the number of doctors being assessed. We also need robust data about our physician workforce so we can plan wisely for future needs. The OMA is developing a tool using artificial intelligence called Prime that analyzes billing data to predict future healthcare needs, such as how many family physicians and how many specialists will be required to meet patient needs in a specific geographic area. This modeling and planning is so important. Alleviating the administrative burden must also be an urgent priority. Reducing the number of hours spent on unnecessary forms and other administrative tasks will give doctors more time to be doctors. At least 1 million Ontarians don't have a family doctor, and that number is expected to grow as a large number of physicians approach retirement age and others retire early or scale back their practices because of burnout. 40% of Ontario doctors surveyed by the OMA said the pandemic caused them to consider retiring early. Family doctors provide comprehensive cradle-to-grave preventative and primary care, and they're the gateway to the rest of the healthcare system, including access to specialists, diagnostics, and treatment. Yet many consider the current situation to be a crisis. We need to address the underlying issues and bring joy back to medicine. The second solution addresses wait times. We need to create a centralized wait list and referral system for surgeries and procedures. This would allow patients with the greatest need to go to the front of the wait list. Wait times were too long, even before the pandemic, with some well above the government's own guidelines. Sick patients don't have time to wait for diagnostic tests, surgeries, or treatments. Many are frustrated, many are in pain and unable to work, and their condition may be deteriorating. Some may be depressed or anxious and unable to cope. Their lives are literally on hold. A centralized system could accept referrals for certain surgeries and procedures, triage them based on medical urgency, and assign them to the next available or preferred physician. Our third solution is about moving more care out of hospitals and into the community, including palliative patients, and equipping all long-term care homes with intravenous and diagnostic equipment to reduce transfers to hospitals. We need to reserve hospitals for patients who need acute care. Many palliative patients occupy acute care beds in hospitals only because they are waiting to be discharged to a more suitable setting, such as a long-term care home, a hospice bed, a hospital-based palliative care bed, or home care. This is stressful for patients and caregivers, and it's a poor use of healthcare resources. It's also costly. The average cost of one day in an acute care bed in Ontario is $1,100, twice the cost of a hospice care bed, and more than 10 times as much as it costs to care for that same patient in their home. We're calling for the creation of 500 new hospice beds. We're also recommending all long-term care homes in Ontario be equipped with the ability to do certain basic diagnostic tests and treatment, like blood work and urine tests, or the ability to administer intravenous medication and fluids. This could prevent unnecessary transfers to hospital. We estimate the solutions we propose for this year's budget that could be costed would total about $320 million for 2023-2024. The new federal funding for healthcare, together with a provincial budget surplus, should more than cover the cost of our immediate solutions and serve as a down payment to implement all 87 recommendations contained in our prescription. We have a panel of experts here today in the room who will talk more about these specific solutions in these key areas and how they could help the healthcare system strain overall. We've submitted our detailed proposal to the Ontario government, and we hope to see our recommendations reflected when it tables the provincial budget before the end of March. At this point, I'm very pleased to introduce my physician colleagues. Dr. Shandy Chandrasena is the Chief Medical Officer of Ontario MD, a wholly owned subsidiary of the OMA, whose mandate is to support Ontario doctors with the technology, tools, training, and ongoing support that they need to manage and exchange patient data to improve patient access to care and patient outcomes. Welcome, Dr. Chandrasena. Also, Dr. James Wright, here in the room, is Executive Vice President of the OMA's Economics Policy and Research Division. He is a pediatric orthopedic surgeon who spent much of his career at Toronto's Hospital for Sick Children, where he served there as Surgeon-in-Chief. Welcome, Dr. Wright. As well, a warm welcome to Dr. Brian Berger. Dr. Brian Berger is the physician leader in the Department of Continuing Care, Rehabilitation, and Palliative Care at Mackenzie Health and medical director of Hill House Hospice. He is also former chair of the OMA's Palliative Medicine section. Thank you so much for being here today, Dr. Berger. So at this point, I am going to turn things over to our expert physicians in the room around the topics that I have spoken into already. We'll start with Dr. Chandrasena. Dr. Chandrasena, how will technology help alleviate really physician burnout? And how can it also help reduce that administrative burden that we know is leading to burnout? Thank you so much, Dr. Chandrasena.
Oh, those are great points. And thank you, Dr. Zacharias. And I'm really honored to be here today. So Ontario MD has done a lot of work in examining the role of technology and how we deliver healthcare. But I'm always really careful to say that technology in itself doesn't cause burnout. So what causes burnout is when the technology is not integrated into the workflow, or it's not developed with that end user in mind, or it doesn't integrate seamlessly with other technology. So I'm a family doctor, and I've been in practice just over 20 years now. And I've transitioned from paper to EMR, electronic medical record. And over time, I've added a number of other digital tools in my clinic. So over the years, I feel that the delivery of healthcare has changed with technology in some ways for the better, but it's also increased that administrative burden. So what do we mean by administrative burden? Well, these are the tasks that have fallen on physicians and clinicians that perhaps in the past could have been delegated to others or were not necessary. So these could be forms like that are paper forms or forms that we have to log on to a separate portal to fill out. It could be not having access to your patient's medical information when you need it. It could be the time needed for charting or documentation, or just sorting through the large number of medical reports and tests that are received daily. There are many tasks that could be automated with the right technology and the right workflow, but it takes stakeholders working together to make these improvements so that the technology is actually a benefit and not a burden. So let's talk about the burden of forms. There are 100 forms that physicians are asked to complete on behalf of patients. So there's no such thing as a quick form. They can have many pages, often asking questions that are not medically relevant and take some time to complete. So, and if there's a new version of a form available, physicians don't usually know about it, and their old version could get rejected. So the forms are still completed as paper and they need to be scanned or faxed. So this isn't always that efficient. So one digital health solution is eForms. So Ontario MD has recently worked with the Ministry of Transportation to develop digitized or electronic forms to help streamline this process. So they're always up to date and they can bypass the fax. But for an eForm to be truly useful, it can't just be a digital version of a paper form. It has to be developed in a different way. It has to include the end user, and it has to be integrated into technology. So more eForms need to be developed, but the process has to be perfected. So done properly, technology works well for physicians and their patients. So let's talk about access to medical information within a patient's circle of care. So this is a common story. So it's that frustrated patient who has to tell that same story over and over again. Their medications, their past medical history, well, really everything. So why do they have to repeat it all the time? Well, it's because their systems aren't integrated. They don't talk to each other. So when you come to me as a family doctor, I'm documenting everything in my EMR, my electronic record, but the ER doc, when you go to the hospital, they don't see that. It's not integrated. Or when you see a specialist, they don't see it. Or the care coordinator that comes to your home. Labs and pharmacies, like tests, none of those are included in a seamless manner. So, oftentimes I might send a patient for another test that was just done. What a waste of time for them. Or the medications like narcotics, right? Like I need to know what's been prescribed so I don't overprescribe. So there's a real need for this integration. So integration or interoperability, it means that the patient's information is available to whoever is providing the care to that patient at that time. So it's what I like to say is the right information to the right clinician at the right time. So integration is absolutely critical. It saves physician time and effort. It reduces that administrative burden. And it really avoids that frustration that patients have when they have to repeat their history and repeat their story many, many times. Medical scribes, so OMA Burnout Task Force, they developed a white paper called Healing the Healers. It's a system level solution to physician burnout. In it, they discussed 5 changes at a system level. 2 of them are related to the work of Ontario MD, which is around that administrative burden and integration of technology. So in terms of administrative burden, I mentioned forms. There's the reports that come in, but the other big task is that charting or note-taking, and that takes a long time. So we have to document the visit. We have to do all the tasks, like order your labs, send a prescription, make those referrals. So a lot of you, when you're a patient, you know this, right? You come into my office, I'm busily typing away on my computer. I'm trying to get that documentation done. I'm trying to get everything done while you're trying to engage with me. And sometimes we're not very good at it because we're so focused on our technology. So one solution is using a medical scribe. So this is a person who's trained to be present during the appointment, to be that note taker, to do those tasks. And they've been found to improve efficiency, reduce administrative burden, and reduce burnout. But what's really exciting is what's coming down the pipeline, artificial intelligence, so AI, and these virtual scribes. The technology is early, but it's being developed. But once perfected, it could automate these administrative tasks and be integrated into our records. So imagine a Siri or an Alexa who's writing the notes. So most of us went into medical school for our love of medicine and that patient interaction. So I would much rather listen to my patient and not be distracted by the technology or the administrative tasks or the hours of work I'm going to have when I go home. But this requires funding, training, ongoing support to adopt these technologies properly and to create that capacity that we so desperately need right now.
Thank you so much, Dr. Chandrasena. I've been in the medical profession long enough to have 20 years ago started out with that pen and paper and the paper medical chart and the filing cabinet and all those things, and always waited for that day when technology would catch up inside our profession. But we have so much to do around integration and not having that take physicians away from the direct patient care that really we always intended to provide when we graduated from medicine. Yeah. So thank you. Thank you. I do think we have some solutions around there. We'll speak even more to that, but thank you very much. I do want to turn things over now to Dr. James Wright and our Executive Vice President in our at the OMA's Economics Policy and Research Department, and to ask Dr. Wright to speak about the centralized waitlist recommendation and referral system, and really how that would be a benefit to the overall healthcare system. Dr. Wright, thank you.
Thanks, Rose, and thank you for the opportunity to speak directly to the media. So, in reducing wait times, we have two solutions. The first, which has received a lot of attention, is the idea of moving some of the lower acuity surgery and procedures into the community. But what I wanted to talk about is the second solution, which is called centralized wait lists. And I want to talk about it from the perspective of a patient. So I think pretty much all of us would have a family doctor that looks after our needs on an ongoing basis. But once in a while, the family doctor needs to refer to a specialist. For example, a surgery, for example. Well, that family doctor then has to send a referral note, which would go to a specialist. And unfortunately, the system, because specialists are overburdened, sometimes they can't accept that referral. Well, then that comes back to the family doctor, who then says, okay, I need to find another person. And they send another letter. Well, that letter may come back. That's enormously frustrating for the family physician. I'm sure it's frustrating for the specialist, but who it's really frustrating for is the patient. Because the first wait is the wait to see the specialist. So a centralized referral system as a first step could actually take that referral, and it would be their job to find a doctor. It's not this back and forth, back and forth, back and forth. So that should dramatically, what we call wait one or W1, that should shorten that list and also minimize the frustration for the physician and reduce burnout. But mainly from the patient's perspective, they need to see that specialist. The second way in which a centralized waitlist may be helpful is some of these specialty centers have been set up across the province, such as low back pain. So the family physician realizes they need the expertise beyond what they have. Well, some of these centralized can say, well, maybe you're not quite ready to see the surgeon. Maybe you should see a physiatrist. That is a doctor who specializes in rehabilitative medicine. So they can triage that. And again, that helps the family doctor and gets the patient to see the right specialist in the shortest period of time. The third piece, and this is the most exciting, is that family doctors often don't know who has the shortest wait list. You might send to Dr. A, or you might send to a Dr. B, who's a specialist, a surgeon, or another specialist. Wouldn't it be great if the family physician could send that referral in, and the referral could go to that doctor that specialist who happens to have a short wait list? We call this W2. That's the step between you've seen the specialist and you want to have your procedure. You want the surgeon or proceduralist who has the shortest time between when they've seen the patient and they actually can do the total knee replacement or the arthroscopy or the tubes in the ears for children, whatever it is. So that's Those are the kinds of things that we want to achieve with a centralized wait list, which is extremely exciting. It's going to require some investment and some coordination, but we believe it can be done. And we think it will substantially improve the access for patients, but also reduce some of the frustration for physicians.
Thank you so much, Dr. Wright. Absolutely. I do want to turn things over now to Dr. Brian Berger. Thank you so much, Dr. Berger, a palliative care physician, for joining us here today. And I would like you to describe really the current situation in Ontario in terms of palliative care and how we are providing or not providing palliative care to our patients who are end of life. And then how could expanding this palliative care create a better experience for patients and even ease pressure on hospitals? Thank you so much, Dr. Berger.
Thank you very much. It's certainly my honor to speak on this topic, which I'm extremely passionate about. So my philosophy is that a society is best judged by how we care for our most vulnerable patients. And I could argue that the most vulnerable patients that we do see are those who are dying. Because if we can provide support to them in a very compassionate, caring basis, that says a lot for the care in our society. Palliative care really is all about comfort care. So it's the physical, emotional, social, spiritual comforts. And in essence, it really shows respect for an end-of-life journey. Originally, palliative care was all about care right at the very end of life, and people may still think of it like that. But more and more, we tend to see patients earlier in their trajectory when they have got what appears to be an end-of-life diagnosis. And from very early on, we can help them steer through some of these comfort milieus. So we do our best as palliative care practitioners to help them with that. Case in point, I was a family physician. I devoted a large part of my career to family practice. But I always did a lot of palliative work, and at the twilight of my career, I'm really practicing palliative care full time. I feel I have a broad perspective because I work in a hospital organization, Mackenzie Health, with which we have 3 areas of palliative care units, besides for providing consultations, and I'm medical director for all those areas. I'm also medical director of our local hospice, Hill House Hospice, which is looking at expansion. And I'm also the community physician lead for our community palliative care outreach group of physicians, providing 24/7 coverage and care for patients. So I feel with all that, I perhaps do have a broad perspective about what's going on. And what I really see as a major issue is the patients who are become more acutely palliative in terms of they have got an end-of-life diagnosis. Things are really deteriorating for them. They're unable to be managed at home for a variety of reasons, and they land up coming to a hospital and they land up stuck in acute care. As Dr. Zacharias mentioned earlier, that amounts to a cost of around $1,100 a day. The question really is why are they stuck in acute care? I can share with you that's not certainly their choice. If people had a choice where they could always be best cared for, many times it will be home. But in order to send people home, you really need good 24/7 coverage for those patients and much more hands-on care. Home care at the moment really costs around $100 a day. What a comparison to $1,000 a day. The thing is that at the moment, and I see it every day, families are expected to carry a lot of the care burden. And it really saddens me sometimes to see and hear from families that they are becoming the nurse or the personal support worker, as opposed to being the wife or the husband or the partner or the child or the grandchild. And how sad is that if they have to be feeling that burden? I feel that the more we put into home care support, recognizing the patient and family's needs and taking that totally into cognizance, we can land up sending many more of those patients that are occupying an acute care bed to the home. In our area, patients who are entitled to the absolute maximum of home care, which is 8 hours a day, is really reserved for people in the last week of life. Well, think about the patients with ALS, with severe end-stage Parkinson's disease, etc. Really, that is very, very difficult for them to be cared for in the home framework, because they may not be in the last week of life, but their care needs are very high. People may say, what about hospices? I can share with you, this is a wonderful alternative to being in an acute care bed in a hospital. A hospice is really 24/7 coverage by a nurse and personal support worker, often volunteers, in a beautiful home-like environment, making the family once again having to be the family, and the nurse, etc., helping with the nursing care. Hospices are great. Unfortunately, we're in total coming up with extra hospice beds that are coming down the pipeline. We'll probably have around 500 beds in the province. If we work on the ideal, which is around 10 hospice beds per 100,000 population, we should have around 1,000 beds to cope with the volume that's needed. And we see that every day. Hospices are forced to turn away patients where prognosis may be a little longer than a week or 2 or 3, etc. And once again, those people are stuck in acute care beds. So by having more hospice beds, we may be able to take people with a little longer end-of-life trajectory, make their comfort that much better, and really help the situation tremendously. The other problem with hospices is, although hospitals are somewhat close to 100% funded by the ministry, government funding only funds 50% of hospice costs. Well, that's an enormous burden on hospices to raise money from their communities. Communities that may not have a lot of financial resources are struggling much more to raise funds for their hospices, and 1 or 2 have had to close over the last few years. And how sad is that? So many are now thinking of expanding. Many are trying to work out how best to do that. Once again, with expansion, the building requires a lot of seed money and then a lot of financial support as well. So everything really gets very tough. Whereas if more funding was devoted to hospices, we'd be able to clear out those patients from acute care. Those palliative patients will be getting, I would argue, a better form of care for their situation. And patients waiting in the emergency could go into the right appropriate acute care bed where they need that kind of care, instead of being lying in the emergency as well. So I think it's a win-win situation for a lot of people. Finally, we can also think of patients going into a palliative care unit at a hospital. We're fortunate that we have that in our hospital. It's a wonderful place for people to be at the end, just to be shifted to a different corridor with specialized nursing. I would argue that that should be supported in each hospital setting as an important place to be. And very finally, long-term care is a good option for people to go back to, but you have to have the right supports in place. You have to have enough amount of staff. You have to have a philosophy where long-term care wants patients like this, because many are refusing patients, saying that their prognosis is too short, and the patient continues to lie in the acute care bed. So long-term care are a very good option, but they need a lot of support as well. Thank you.
Thank you so much, Dr. Berger. I really appreciate all of that. Actually, as a family member that lost a loved one in the last year who was able to be at a hospice facility, it just highlighted experientially so much of what you speak to. And also we know as a society. It reflects on us how we care for our most vulnerable, as you said at the top of your remarks. And it is the care that physicians want to provide to our patients. Thank you so much. Thank you to all of our panelists, Dr. Chandrasena, Dr. Wright, Dr. Berger. We are now going to open up the question and answer so that we can get specific. You can direct your questions to each of the physicians in the room. The OMA's Emily English is going to moderate this portion of the Q&A. If we don't get to your questions due to time, the media team will definitely follow up with you. You can also email at oma.org. We'll make sure that's in the chat with additional requests for interviews. And we are going to have a recording of the session available later this afternoon. So I'll hand things over to Emily, and the four of us are ready to take any of your questions. Go ahead, Emily.
Thank you, Dr. Zacharias. The first question is for Dr. James Wright. It comes from Marjo John from the Medical Post, and it's about the centralized wait list. So what kind of infrastructure will need to be in place to make the centralized referral system happen? How many people to staff? What technology is required? And how do we make sure we have the means to gather the data needed for this? For example, in terms of specialist wait lists, how would this information be obtained and kept up to date?
So that's an excellent question. This is why what's called WTIS, which is the Wait Time Information System, which currently is a comprehensive measurement of the decision to treat and when surgery is received. So when a surgeon or a proceduralist knows that a patient will need that, they are registered in the WTIS, and then the time at which the patient actually receives it. And that gives you a sense of what the wait for an individual surgeon or someone who does procedures. So the idea to begin with is surgery and procedures to link to that data, to use either people or software that would allow a family physician together with their patient to go on to a website. The website is currently there, the WTIS, but it doesn't do the kind of matching that we would like to see. So you can imagine that a patient would say, listen, I want to have the procedure as close to home. Okay, well, that would be a certain geographic, all of the specialists within that region. Or the patient may say, I want the shortest wait list and I'm willing to travel. Okay, let's say you lived in Kingston, you might be willing to go to Smith Falls, or you might be willing to go to Ottawa, or you might be willing to go to North Bay if you knew you could get the procedure. There's also some patients and some who want to go to a particular physician or a couple of physicians. So that's the kind of function that we would build into the system that would allow the patient and the family physician together to get that into the system as quickly as possible. How many people? I don't know yet, but that's what we need to do, is map out all those things and then support it and make it function. Just so you know, we have a similar system called Critical, which manages if a patient is in one hospital and needs to be transferred to another hospital. We have a functioning system which works very well and helps the referring hospital get a patient to the receiving hospital. So we do have experience in this province, and it's a world-renowned experience. So let's build on that and do the same thing for procedures.
Thank you very much for that answer. The next question is for Dr. Chandrasena. It's about fax machines. So you mentioned how electronic medical record systems don't all speak to each other. So given that we know a lot of doctors are still using fax machines, can you talk to us about how that contributes to the administrative burden?
Yeah, you know, I think I could probably talk for hours about the fax machine, but I think it's important to realize that it's not just physicians that are using the fax machine. It's also the recipients on the other end, and it's a lot of healthcare, and we're all connected through the fax machine. So in order to kind of bypass the fax or axe the fax, it has to be very thoughtful. And you might have heard in my opening remarks that I was always talking about integration. and looking at the end user, looking what's happening in the offices that are using these fax machines, making sure it's integrated into the technology seamlessly, because that's really important. It's not enough to just say no more fax machines by this date, because that's not realistic, because you need to find a technology to replace that. So we do have technologies that replace that. We have what's called HRM, which is a hospital report manager, which is like a conduit for the hospital to send reports to the community. And that's seamless. That bypasses the fax machine. There's other technologies that are there. But at the end of the day, the fax machine is secure. And when we say fax machine, I also want to be a bit deliberate in saying that also includes eFax. So right now in my electronic medical record, I can eFax something seamlessly. Like literally, it's just a couple of seconds, it's on its way. So in my mind, I feel like it's technologically integrated, but it's really just a fax machine. It's just an electronic version of it. So to bypass that, you need to come up with a technology that's just as seamless, because that administrative burden, it cannot be undervalued. It's huge, and it really impacts patient care and the time that it takes. So I think in order for us to get rid of the fax, I think it's something we need to work towards. It has to be a long-term plan that really looks at how do we integrate it into workflow? How do we make it easy? How do we make it seamless? And how do we truly find solutions that work and not kind of stopgap kind of ideas that don't really integrate?
Thank you very much. And the next question is for Dr. Berger. You've told us about the need to expand palliative care. How many more palliative care beds should Ontario have?
Thanks for the question. I mean, that's quite a broad sort of question, because basically, we know that in any time, at any given time in the hospital, somewhat of around 50–60% of patients are really within their last year of life who are occupying an acute care bed, and their acute care needs are have been met. So if you work out how many patients that is that need palliative care beds, that's a lot. Clearly, we know that extra 500 hospice beds will make a difference for many of those patients. Having the patients out in long-term care as well, increasing long-term care capacity to accept new patients like that would help a lot. To have obviously many of those patients going home would help a lot as well. And I think all in all, if you can decrease the amount of acute care patients stuck in the palliative patients stuck in those acute care beds, that'll make a tremendous difference. In our hospital alone, I mean, we've tried to help the situation by expanding our own palliative care beds. We went from 8 to 12 to 14 to 16, and then we added another 4 in our other site at the Cortalucci site, which is 20. We added another 12 in the reactivation care center site. Like, we're trying our best to manage those people with like 32 beds, and we just sometimes, we cannot keep pace with the amount of people that we need to try to move into those beds, being mindful of the fact that we can't have them also occupied for a very, very long time, because then we haven't got room for people right at the very end of life. And we've tried our best, and some hospitals have done it better than others. I'd argue we've done it quite well. We have complementary therapy there. We have music therapy. So instead of having the standard acute care things like occupational therapy, physiotherapy, etc., we've sort of highlighted other parameters that we believe are more important at the end of life sort of situation. And if only that can be transmitted over to long-term care facilities, and it is already transmitted to hospices, but more within hospice settings, I think that will make a very big difference. An exact number is difficult to extrapolate, but just look at the fact that the majority of the patients who are waiting, that are alternative level of care and acute care, could really be moved to an appropriate place. Thanks.
Thank you very much. And the next question is for Dr. Zacharias. Could you put the administrative burden into context for us? How much time would doctors be spending on administrative work versus seeing patients?
So we know that, ultimately we want doctors to be doctors. We want doctors to be cultivating those relationships of trust with their patients, navigating their medical conditions, their diabetes, their high blood pressure, talking about preventative measures to decrease the risk of a life-altering stroke or heart attack. And we want family doctors to navigate the system for us, to send a referral to a pediatrician, to a dermatologist, to a surgeon when we need it. And what takes up doctors' time is computer work, forms to be filled out, charting. We have a medical legal responsibility as physicians to document every one of our interactions in detail. And when the fields we're populating inside of our computer continually glitch or are not integrated with the specialist's computer system, for example, or the pharmacist's computer system, for example, or the physiotherapist's computer system, or the social worker, every single one of those forms needs to be kind of opened up, a new interaction face, and it just all takes time. Not to even speak about the notifications that will pop up, sometimes very poorly labeled. A doctor will get sometimes 50, 60 notifications that's pertinent to one patient visit, and you want to open them all up. What is relevant with regards to that patient having been hospitalized recently or have been visited by the dietitian recently? What is relevant to this visit? I have to review all this. It takes me 30 minutes to review it all for a 10 to 15 minute encounter. We know that on average, doctors are spending about 10 to 12 hours per week just at their computers. And if you imagine all the docs in Ontario, and you could reduce their paperwork responsibilities by even 1 hour per day, they could see 2 more patients per day. And that would tally up to 1 million patient visits extra in 1 month. Doctors want to see patients, and yet we have responsibilities. The administrative burden is just too onerous. It's why doctors are leaving the profession or doing their best to modify their practice, scaling back to do it all. And we don't want doctors to have to do it all. We want to equip them, empower them, and so alleviating the administrative burden, not to speak to just the patient access issue, but that every physician who has a moral conviction to do right by their patient just wouldn't be stuck at their computer, sometimes late into the night with a work day the next day, or an entire weekend wiped out, not spending time with their families, or just the personal refreshment that they need away from their desks. We could just do a lot of good for the healthcare system, for the physicians involved, for our patients ultimately. Thanks.
Thank you. And the next question to follow up on that is for Dr. Chandrasena. Could you tell us about some of the common forms that doctors have to fill out? And also, why is it that office staff can't help fill out these forms?
Yeah, so I think the first thing I want to kind of point out is that it could be a form, it could be like a piece of paper, it could be a portal. But that form, the end result of that form is that it's a patient at the end of it. So that patient might need a paycheck. That patient might need this form in order to get some medical device. That patient would need this form so that they can go on disability and still have money coming in. So every form, like as we're talking about these forms, I want everyone to understand that each form is really important. And that responsibility is on the physician, because they understand that if they don't fill out this form in a timely manner, if they don't fill it out properly, it's going to have a real impact on someone's life. Like, it's not like these forms are coming just for fun, right? Someone on the other end is waiting for those forms. So I think that's really important to put in perspective. And so when we talk about forms, there's so many types of forms, and there's actually OMA has a forms committee that's looking at these forms and kind of saying, is there a way we can standardize them? Is there a way that we can make them shorter? Is there a way we can make them relevant? Because some of the questions on these forms that outsiders are asking, like insurance companies are asking, the government is asking, are not forms that need to be filled out by physicians. They could be filled out by patients. A really quick example is like these forms that say, can you walk 2 blocks to your car? And I'd be like, I don't know. And I ask my patient, can you walk 2 blocks to your car? And then they'll say, no, I can. Then I'll be like, no, they can't. So that's like a very simple example, but those are one of many examples where, you know, these forms are not relevant. Like, I don't need to fill these out. These could be filled out by people who are way more knowledgeable than me when it comes to that. So when these forms come, there's no such thing as a quick form. I'm going to tell you right now, I'll have patients who'll be like, I just have this form. I just need your signature. But my signature means that I've reviewed it. I've looked at the chart. I've given you a medical judgment. And then that means that I'm responsible for whatever I write. So every form requires me to know you, know your chart, go into your information and make sure that I'm filling it out properly. Because I also have a responsibility to the system. And I'm also held to a higher standard when I fill out these forms. So that's a part of it. So I think what we want to do is look at these forms, see what actually needs to be filled out, and then find an easier way of doing it. The reason it can't be delegated is because a lot of these forms are asking medical opinions. So maybe someone could like type in the demographics, but then wouldn't it be great if that was integrated in my EMR and that just pops up? They can ask about medical opinion, but at the end of the day, I'm the only one who can enter that. And then the judgment call, like I'm the only one who can do that. And so I think that's where the problem is. So we need to advocate for less forms that are medically relevant. So you've got the right person filling the right portion of the form, and best practices to how that form is going to be filled out. I get about 1 to 2 forms a day. And then I get the insurance forms, which take me hours to fill out. So if you're kind of wondering, like those are hours of time on the weekend after work that I'm filling these forms out. And I think we really need to look at that.
Thank you very much for that answer. We have another question for Dr. Jim Wright. Dr. Wright, the OMA is developing a tool using artificial intelligence called Prime. Can you tell us more about what information it would gather and how it would be used?
Yeah, thanks, Emily. This is incredibly exciting. I think we've been hearing about artificial intelligence for a while, but many people have tried chat GPT and they're suddenly like, oh my goodness gracious, this is a tool beyond we ever imagined. We've also heard a lot about shortages of family physicians, and we've heard about insufficient numbers of physicians in the north. So this is something collectively, we've heard about this from the federal government and the provincial government. We need to get a handle on who's where and can we meet the needs of the population. That is a wonderful first step. But what we really need to do is predict into the future, because we can't always be, dare I say, chasing our tail. We need to begin to anticipate some of those needs. So that's what this model is. It's going to start to allow us to predict what kind of physician we need. Is it a family physician? Is a specialist? What kind of specialist? And where might they be needed? Is it in what parts of the province? So you can imagine this is an incredibly complicated challenge. It's going to require input of population needs, and we have ways of predicting based on the population within a region that we anticipate in the future they're going to need these healthcare resources. We have some good information on physicians and the kinds of physicians that are coming through the pipeline, as it were, through medical school and residency, and that gives us some idea of what the supply is going to be. And then we have this really amazing, cool thing called artificial intelligence and this model that'll begin to give us some sense of what those needs are and anticipate those needs. And the thing about artificial intelligence, it gets better and better and better. It's a machine, but it learns from what it did in the past, which this model is only going to get better as we feed in more information. So an incredibly exciting thing. And as far as we know, this is the first time worldwide artificial intelligence has been used for health human resource planning in the future.
Thank you very much for that answer. And I have another question for Dr. Berger. Can you tell us how long are palliative care patients staying in ALC beds in hospital?
So that's a very good question. There are people that are staying sometimes up to a year, which is quite frightening, and many times up until their death. Basically, 44% of patients in the acute care section at any given, 40% of the patients are sometimes up to 40% of patients are alternative level of care patients. 44% are often waiting for a long-term care bed. 24% waiting for a residential hospice. 12% are waiting to go home. These are all palliative patients occupying an acute care bed. 30% actually die before they were supposed to be discharged, when they were supposed to be discharged. So they're dying in an acute care setting. Not ideal at all. In terms of numbers, these fluctuate a lot, but all I can say is it's a large number of patients. And the problem is that the time to get into a place is really, really long for many people. It's almost a lucky break when they can get into a hospice. And also getting into a palliative care unit does provide somewhat of a stopgap. But I can tell you, long-term care, most of the patients we take to the reactivation care center, which are people with a longer palliative care trajectory, at any given time, week after week, when we do our rounds, the same patients are mentioned, and they've got 4 or 5 long-term care facilities that families have put down choices for, and all the time they're waiting, because all the time it happens that the long-term care facility looks at this and they say, this patient's only going to be with us for 2 or 3 months or up to 6 months. Maybe we'll take someone else. So it's just an unfair situation where people are lying in a bed in a hospital setting that they don't have to lie there. Thank you.
Thank you. And we have another question for Dr. Zacharias. This is from Rebecca Chouinard with Blackbird Media. Is the government on board with these solutions? How will the OMA lobby the provincial government for the investment of $320 million towards these solutions?
We do believe the government is listening. As physicians, we, nearly 100 of us were at Queen's Park in November. It was a good day. That was a very intentional, strategic dialogue that took place between the physicians and our politicians. And we had the Minister of Health attend a panel over the noon hour, and we presented very clearly our prescription for Ontario, our 5-point plan, and the 87 recommendations. We refer to those, but we speak about immediate solutions that can be implemented now. And when we see announcements around integrated ambulatory clinics to catch up on the surgical backlog, well, we know these need to be integrated, these need to be publicly funded, these need to have a human health resource strategy embedded. We want to continue to be at the table when it comes to implementing the solutions. And we will be releasing a refreshed prescription for Ontario, and also a progress report that really outlines the progress that has been made on the OMA's most extensively consulted document around what is important to Ontarians when it comes to our healthcare. Ultimately, the accountability, I mean, we need to do right by our patients, and ultimately the accountability will be, are we doing right by our patients? Are there people who now have family doctors who don't haven't had family doctors for years? And are people getting in for their surgeries and procedures and not waiting as long? So we know that our solutions are geared towards that. I'm an optimist, and I do believe that those with the political power can make good progress towards doing right by our patients, and we are committed as the physicians in Ontario to continue to work with government, all levels of government, to see that through.
Thank you very much. And a reminder to journalists, you can put any questions in the Q&A chat and we will get to them, or you can follow up with us afterwards, media@oma.org. But if you have any questions, please put them in the chat now. I do have another question for Dr. Wright about the centralized referral system. Can you tell us more what procedures this would be used for?
Yeah, so we have to do this in stages. I think that the first thing is virtually every operation, every surgery in the province is in the WTIS, in the wait time information system. So I think we would want to work with the government, building on Dr. Chandrasena's point, to have an interface which is easy for family physicians and me to use. So I think that's the likely place, is to start with surgical procedures in the province, and then we can begin to expand beyond that to other disciplines. It's a little more complicated because we don't know what the weights are in other disciplines, but there are ways of collecting that information ultimately. So that's, I think, the most appropriate first step.
Thank you very much. And those are all the questions that we have for today. So I'm going to pass it back to Dr. Zacharias for some closing remarks.
Thank you, Emily, so much for your moderation of the Q&A, and our panelists, absolutely, for your contributions to the answers given. Dr. Chandrasena, Dr. Wright, Dr. Berger, thank you so much for being here today. And for everyone in the room, indeed, you are tasked now with the message crafting. This is Ontario's physicians coming forward to speak to the solutions very specifically around what is inside of our prescription for Ontario, and we thank you for your time and your good questions and your listening. We will continue to advocate for solutions to strengthen Ontario's healthcare system and increase our patients' access to care. We can't let patients struggle to get the care that they need. Ontarians deserve good, high quality, safe, compassionate care. And physicians are highly resilient and have individual capacity, but our healthcare system has fractures that are burdening those of us who want to provide good care. Addressing the gaps in our healthcare system needs to be a priority. Thank you, everyone, for your time, and I wish you a good rest of your day. Bye.